Good Uh, Good evening, everyone. So, in the series of our discussion about uh, planning the uh, decision making in hand surgery. So, in the series of our discussion about uh, just sorry for this.
Yeah, yeah, yeah.
We are going to discuss about the decision making in hand surgery. So this time we are going to discuss the scaphoid non-union, decision making in scaphoid non-union. And at this time we are having combined platform with the Indian Society for Surgery of the Hand and Indian Orthopedic Association. So first of all, I would like to invite Dr. Parveen Bharadwaj, Secretary of ISSH. He will say a few words about our program. Sir, Dr. Parveen, sir.
Yes. Thank you, Amit. I think it is very unique and wonderful opportunity for ISSH to have a combined meeting with IOA. Thanks to you and thanks to Abhijit. Thank you, Dr. Rajiv. And I always thought like we should have a combined meeting because we all are orthopedic surgeons, but we are not getting into any orthopedic stream. And this scaphoid fracture, what you have specifically selected, is a very orthopedic topic, which I'm sure a lot of orthopedic surgeons would be doing. And if we are able to convey a correct decision-making protocol, all will be benefited a lot. Thanks for selecting this topic, and hopefully we'll have a very fruitful discussion. Thank you.
So now I will hand over to Dr. Abhijit Vayegaonkar for further proceedings.
Thank you. Good evening, everyone, and welcome to this wonderful webinar. And I think we are all about joining hands and creating bridges in order to facilitate and enhance learning for all and for every member of each society, for that matter. In this case, I think this is for the first time ever that the IOA and the ISSH are teaming up, thanks to the leadership and also the free hand that the IOA has entrusted me with in conducting these educational programs, and the wonderful faculty and colleagues that we have. It's about kind of working collectively, and I'm very grateful to the IOA, especially Dr. Rajiv Raman sir, to whom I'll hand over the mic in just a couple of minutes. But I would like to take this opportunity to thank him, because the moment I had expressed my interest in taking up hand surgery as a subject and trying to create educational opportunities and webinars and CMEs all across the country, he just said, Abhijit, go ahead with it. And I'm very, very grateful to the IOA the leadership, Dr. Rajiv Raman sir, Dr. Anup Agarwal in the past, who is now the past president, as well as Dr. Naveen Thakkar sir, who is the current president of the IOA. Not only that, our members at large, Dr. Amit Vyas, Dr. Ajit Tiwari, Dr. Ravi Bharadwaj, as well as Dr. Amit, uh, अपने जो इसके
Satya. Satyavamshi.
Satyavamshi, Satyavamshi, they have all been very helpful. And I think going forward, this is perhaps the way that we will be working. Thank you very much for being here with us. I request our secretary of the IOA, our dynamic secretary and our ever helpful secretary, Dr. Rajiv Raman sir, to please address the meeting. Thank you very much. Thank you.
Thank you, Dr. Vijit, and greetings from Indian Orthopedic Association. I think this is a wonderful initiative by ISK, having a webinar series with IOA. IOA is always there to help the subspecialty, and I would especially thank Dr. Avjit for making so much physical and webinar series with the IOA. He has done a lot, and I think last year he conducted 6 to 7 IOA hand courses. Looking forward for more collaboration. Thank you so much. And we want more hand courses with the ISK under banner of Indian Orthopedic Association. Thank you, Avijit.
Thank you so much, sir. Really appreciate, and especially for taking the time in your very busy and hectic schedule to be with us. I really appreciate it. I request Dr. Amit Vyas to take over the proceedings and we can start the meeting. Thank you very much.
Thank you, sir. Thank you all. Without wasting too much time, we'll start our meeting. So in this meeting, first we'll go one lecture by Dr. Ravi Bhardwaj sir from Kolkata. He will give us guideline how to approach for a scaphoid non-union, and then what treatment studies should be planned. Then we'll do few case discussions. So first of all, I would like to invite Dr. Ravi Bharadwaj sir for his lecture. Sir, please share your.
Thank you very much. Yeah, so I need to sort of can you make me the co-host? So I'll then share my screen.
You can start sharing, sir.
Okay, good. Okay, just let me know if I'm visible.
Yes,
Is my
Ravi.
screen visible to all of you?
Yes, sir.
Yes, visible.
Yes, sir. Yes.
Right. Okay, so thank you very much for the opportunity, Dr. Amit Vyas, and I would like to extend my heartfelt thanks to my colleagues both in the IOA, Dr. Rajiv Raman, and all my colleagues in the IOA, and also my colleagues in the ISSH fraternity. You're more like family to me, and this is a topic which is very close to my heart, and I've always wanted, a collaboration between the IOA and the ISSH. And thanks to the leadership of our dynamic secretary, Praveen Bhardwaj, and also our dynamic secretary in the IOA, Dr. Rajiv Raman, and the efforts of my dear friends Abhijit and also Amit Vyas, Ajit, and Satyavamsi. I mean, I'm sure we're looking forward to very exciting times ahead. And I hope, like, this series of educational webinars reach out to, the people who require it the most, the practicing hand surgeons. And, hand surgery, I think, is not very given its due importance, as I feel, in the undergraduate curriculum and the postgraduate curriculum. Yet when it comes to practice, we see a number of cases, and then sometimes, there's a little bit of a lacune in knowledge and decision making, and that's where these webinars will probably go a long way in plugging that gap. So without wasting much time, the topic today is scaphoid non-union, and it's very relevant to all practicing orthopedic surgeons. So I'm specifically going to talk about scaphoid non-unions, the natural history, why this is important, and what are the diagnostic modalities, what sort of, when to use a CT, when to use an MRI, what information we glean from them. And, there's a lot of controversy about, when to use a vascular graft, non-vascular graft, what works where. We'll look at a little bit of literature also, and then hopefully we'll try and arrive at a consensus. So that's how it's going to pan out. So I would like to declare that I have no conflict of interest with regards to this presentation. So if you look at the definition of non-union, it is defined as the failure of non-union of union and a scaphoid fracture following cast immobilization or surgical treatment of 6 months duration. This is the official definition given to us by Green's Operative Hand Surgery, which is the Bible we all fall back to. And if you look at the prevalence of the scaphoid non-union itself, it's 0.14% in asymptomatic population. It was a study by Bannister et al. In 2000. How can a scaphoid non-union present to us clinically? It can take various forms. So it could be, that it presents as a non-union, which we have picked up initially, and we go on to proceed to treat conservatively, but still the fracture does not go on to unite. So this is about 12.9%. And Joe Dias published from, Leicester in 1989. It can be that the scaphoid fracture was treated conservatively, but the patient did not fall out. That's another scenario. You could have a fracture which was undiagnosed to start off with, but then later on starts to get painful after another fresh injury, and that's when it's picked up when imaging is done at that stage, and the patient recollects a past injury many months ago. Or it could also take the form of an undiagnosed scaphoid fracture, and probably the patient had some other injury and the X-ray was done incidentally, and then this fracture decides to show up, the non-union. So that's also another way it could present. So these are the usual presentations. So brings us to the next question. Why such a big fuss about the small bone? And most of our orthopedic colleagues would be asking us the same question. Why is it worth all the trouble, and why are we here, on a Monday evening, spending more time to learn about this little bone? So the answer is, like, we have to understand the natural history of what an untreated scaphoid union can lead up to. So the natural history of an untreated scaphoid non-union is, what happens is the proximal scaphoid fragment remains attached to the lunate through the intact scapholunate ligament. The distal scaphoid fragment rotates into flexion, and that leads to abnormal contact in the radioscaphoid compartment. And this leads to, in turn, altered biomechanics, and which leads to more friction and early OA between the distal scaphoid fragment and the radial styloid. And this arthritis only goes on to proceed to 4 stages. So this ends up in what is called a SNAC wrist. We hand surgeons like our acronyms, and the SNAC stands for scaphoid non-union advanced collapse. And you can see here, if I can show with my pointer, in the first stage, there's only radiostyloid osteoarthritis. Further on, it goes in a circular pattern. The stage 2, you have scaphocapitate OA also. Then in the third stage, you get stage 2 plus lunocapitate. So between the lunate and the capitate. And stage 4, you get pancarpal arthritis all around. So obviously, an untreated scaphoid non-union is not good news. It's going to progress into a SNAC wrist, and that's the reason why to pick these up early and treat it so that we can arrest the progress. So continuing with the natural history of an untreated scaphoid non-union, let's look at the literature. 30 patients are asymptomatic initially, but 70% will have pain, tenderness, and loss of motion. These are some very early studies. But then in 1984, Lindstrom holds good even today. Osteoarthritis will occur in all patients despite being asymptomatic initially. And if you have a non-union which you pick up in maybe 5-6 months down the line, and then you are having a difficult time to convince the patient what is initially a painless condition can go on to give a lot of grief in the past and in the future. And that's why that needs to be dealt with immediately. And that's sometimes very difficult to convince the patient to undergo surgery. So the important thing to remember is all symptomatic patients with non-union will develop osteoarthritis within about 8 years. And that's a study by our friend Ruby Grewal et al. From the United States of America. And let's now talk a little bit about the factors which cause the non-union scaphoid. And then, as I said, why so much fuss about little bone? It's good to understand the biomechanics and the biology and the anatomy of scaphoid non-union. So basically, you have to understand that the scaphoid is a bone which is essentially devoid of periosteum. So the periosteal contribution to callus is very little. Most of the healing is endosteal. It's an intra-articular fracture, so there is synovial fluid ingress into the fracture site, and that sort of dilutes the fracture hematoma and the bridging callus which can form. The scaphoid is a unique bone because it crosses both the carpal rows. It's a component of both the proximal and the distal rows, and that gives rise to more mobility. And because with every wrist movement, there's movement translated to the fracture site, and this stops the fracture from healing. So mobility at the fracture site is not conducive to bone healing. The fracture itself, because of the deforming forces to the various ligaments which are across the extrinsic and the intrinsic ligaments in the wrist, cause the fracture to be unstable. And you can have, an intra-scaphoid flexion also, sometimes because of the pull of the various ligaments and the muscles. We have been taught a lot about the vascularity of the scaphoid even in undergraduate days. So we all know that essentially the blood supply to the scaphoid is retrograde, and any fracture to the waist of the scaphoid will result in impaired vascularity to the proximal pole. And there have been studies to show that the more the proximal the fracture is, the greater the impairment of vascularity, and therefore the greater the chances of complications such as avascular necrosis. Then comes the matter of displacement. If you think about it, there's not a lot of bone contact between the two fragments. So if you think of these two circles, if you take a large bone like a metacarpal fracture or something, there's a long oblique fracture. There's a lot of contact. There's essentially a lot of scope for callus to form and union to happen. But if you take the case of a bone like the scaphoid, a carpal bone, which is inside the joint, essentially, the contact surfaces, even at the best of time, the fracture is not displaced very much, is tenuous to say the least. And even with a couple of millimeters of displacement, you can see the two concentric circles going, more and more divergent, almost like a Venn diagram with very little intersection. So this common area is only the contact area, and you can make sure, with the bone which is intraarticular with synovial fluid constantly moving all the time, this is not amenable to union. So these are some of the factors which cause scaphoid non-union. So, which brings us to the next question. Then, why do we want to fix these fractures in the first place, and how does the fixation affect the non-union? So, you know, once we reduce the fracture, we improve in the contact area instantly, and we give the fracture a better chance at healing. And then once we freshen up the fracture site and compress it with an implant like a screw, or even maybe when we hold it with a K-wire, this prevents the synovial fluid ingress. It tries to stimulate primary bone healing, endosteal healing between the two fragments. You're reducing the fracture mobility and you're giving it more stability and therefore giving it a better chance at healing. So the osteogenic healing, across the fracture gap, it stands a better chance because of fixation of the fracture. And then there is also this thought of that it how it affects the vascularity, because once you fix the fracture and give compression, there is potentially more scope for bone growth across the fracture site, and even the small blood vessels which cross the fracture site. And also reducing the fracture, some of the blood vessels which are kinked, and the tenuous blood vessels, you are restoring it to its original place. So fixation does affect the vascularity indirectly also. So, what are the investigations we are talking about? We might have had a clinical suspicion of a scaphoid non-union, and then we have gone on to do a standard scaphoid series of X-rays, which includes, 6 views. We are doing the PA view and ulnar deviation. We are doing the lateral view, the oblique views, and and the AP views, the scaphoid view of 6 series X-rays, and we have identified a scaphoid non-union. Is it necessary to get additional investigation? The answer is yes. Before you're going in, you need all the information needed. So many of us talk about whether to get a CT or an MRI, and now we have to understand that these are not necessarily mutually exclusive. It's not like whether I choose a CT or an MRI, depending on the situation and the scenario and the duration of the non-union and what your information your X-ray gives. You might want to get additional information from a CT scan. You might want an MRI scan as well, and you might want to get both. So they're not sort of necessarily independent of each other. It just depends on what kind of information you're looking at and what your treatment strategy is going to be. So especially in a proximal pole non-union, you might want to get both a CT and an MRI scan for different reasons, which I'll allude to in a moment. So if you talk about CT scan in a scaphoid non-union, you're talking about, a precise, idea of the fracture site, because sometimes you think it's whether it's a waist, whether it's more, encroaching towards the proximal pole, you want more clarity about the fracture line. Well, a CT will give you a three-dimensional idea of that. It also tells you about the fracture configuration, whether it's a transverse fracture, whether it's an oblique fracture, which direction your screw is more likely to give you compression, and so on and so forth. It tells you whether the fracture is displaced or not, and how much offset it is, whether there's an sclerosis at the fracture site which needs to be freshened, and then what the biology is, whether there's any cyst formation or cavitation at the fracture site. And whether there's an element of intrascaphoid flexion or a humpback deformity that's best assessed on a CT scan. You can even measure the angles. And for planning a graft harvest, if you're planning a correction of a humpback deformity, a CT scan is comes in very much handy. It might also, be useful in picking up osteochondral fragments in other carpal bones. Sometimes that might be the case. So MRI, you're looking for a different, subset of information. Usually, if you use a gadolinium enhance, you get, enhancement, you get more imaging, and it's usually done to diagnose avascular necrosis. Now, I have to advise a little bit of caution because, the way you need to interpret the MRIs, most of the time we just write X-ray, MRI wrist, and the report comes back, and when there is signal intensity, many radiologists, erroneously reported as avascular necrosis, and that adds to the chagrin of the operating surgeon, because unless you learn to interpret the MRIs yourself, you don't need to be an expert radiologist, but even whatever is relevant to you. A couple of points I would like to highlight, and I think all of us should be aware of this. So to diagnose avascular necrosis of the proximal fold scaphoid on MRI, you should look both at the T1 and the T2 weighted images. And what you're specifically looking for is a diffusely low signal intensity on both the T1 and T2. So it should not be confused with marrow edema. Suppose you get a lighting up on the T2, in the proximal pole of the scaphoid. Many a time it is erroneously reported as, avascular necrosis, and you take the radiologist report as the gospel truth, and that swings your decision to a vascularized graft. That's not necessarily the case. You look for yourself, look at the films and see whether there is a low signal intensity on both the T1 and the T2. Only then you decide whether it's a possibility of A1, avascular necrosis. And also then you would just go in with your perioperative findings, which I shall allude to in a moment. So what's the aim of surgery? We are trying to restore the carpal, biomechanics. So we are trying to restore the length of the scaphoid, the alignment. We are trying to offer stability and compression for reasons I mentioned earlier. We are also specifically in a non-union scenario, the first few factors are, even in any scaphoid fracture with displacement, we would do the same thing. What we are doing additionally in a scaphoid non-union is, in addition to the mechanical stability, we are trying to also improve the vascularity and also improve the osteogenic potential. And how do you do that? We can do that by taking recourse to some sort of grafting. It might be a cancellous graft, a corticocancellous graft, can be non-vascularized, vascularized, free vascular graft, or a pedicle graft. We shall talk about that in the next few slides. So if you talk about scaphoid non-union classification, can I ask someone to turn off the speaker? Can everyone go on mute, please? So there's some added noise, if you don't mind. Thank you. So if you look at the classification of scaphoid non-unions, we're talking about delayed union. We see these kind of presentations occasionally. You could have a scenario of an established non-union where there is no deformity or arthritis. It could take the form of a fibrous non-union of the waist or a sclerotic, non-union of the waist of the scaphoid. You could have a scenario with a humpback non-union. So these are all established non-unions. These are the various scenarios. And then there is a category of proximal pole non-unions where there is no avascular necrosis and the proximal pole is very much viable. And then there is a scenario where you have a avascular proximal pole, whether the fracture is at the waist or, a proximal pole. But, the MRI and other studies and the clinical findings perioperatively seem to indicate a dysvascular proximal fragment. So these are the types of non-union which are classified clinically, and we shall address that with what to do in terms of management. We're trying to build a treatment algorithm here. So it is the later ones which are sort of called the scaphoid at risk, and these deserve a little bit of extra attention and more detail, and we shall address that separately. So if you talk about the classification and treatment algorithm, which we generally follow based on the type of the fracture non-union. So basically, if you have a delayed union, the consensus is to treat it with the mini open reduction internal fixation. Some sort of bone grafting is always advisable, just to aid the biology, unless it's very fresh, when you can just drill the fracture site and simple compression offering stability will be enough. For establishment non-union without a deformity or arthritis, the whether it's a fibrous or a sclerotic waist non-union, the consensus is to go for an open reduction and bone grafting. You could do it via the dorsal or the volar approach. If there is a component of a humpback non-union, then obviously you're going to take the volar approach and restore the intrascaphoid height and the scaphoid height and correct the intrascaphoid flexion. You could do, Or you can use bone pegs like the Matty Rossi has described, or you can use the Fish-Fernandez intercalated wedge autograph also to correct the humpback deformity. And for proximal pole viable non-unions, you can use a dorsal approach. You can use a mini, percutaneous or bone grafting technique. And in addition to sort of your bone grafting and fixation of the proximal pole, usually with the mini HCS or even small screws or K-wires, depending upon the size of the fragment, you might opt to give more stability by temporarily pinning the scaphocapitate joint to reduce the forces across the fracture site, the non-union site. And in a dysvascular proximal pole, you would opt for either a vascularized or a non-vascularized graft or an osteoarticular graft, depending upon the scenario. So the common surgical approaches when we talk about when we are dealing with scaphoid non-unions are a volar approach, mostly for waist fractures, and especially when you're dealing with the humpback deformity, we want to correct the intrascaphoid flexion, you would always opt for a volar approach. This approach has been popularized by Garcia Elias. It's also called the Garcia Elias approach in line with the FCR tendon and along the line of the scaphoid distally. You have the dorsal approach, which is centered on the distal, the distal tubercle between the third and fourth compartments. You enter the wrist after making a retinacular incision, carefully retracting the tendons, and you make a capsulotomy, an inverted T shape, and flexing the wrist will give you the access to the scaphoid, the proximal pole, and depending upon whether you want to take a bone graft from the distal radius, you can extend the incision a little bit more proximally to help you harvest the graft. And then if you're planning a vascularized graft, for example, the most commonest pedicle bone graft is the Zeidenberg graft, the 1-2 suprareticular artery, then you would require a dorsal-radial S-shaped incision. That's usually helpful. And nowadays, there has been an increasing tendency to do a lot of these surgeries arthroscopically. So surgeons who are adept at wrist arthroscopy address many of these non-unions arthroscopically. So, the scenario of delayed union, which I mentioned. So, what is the treatment protocol? You confirm the suitability of fixation, especially if you're using a mini open approach. You have to make sure it's reducible, the fracture is not displaced more than a millimeter. And then you can fix it with the headless compression screw with the mini open technique, and you can use cancellous bone graft or bone substitute also. And the use of a headless screw always helps achieve compression at the fracture site, and that improves the stability and gives the fracture a better chance to heal. In the scenario when you have an established scaphoid waist non-union with no arthritis, you could use either a cancellous graft with screw fixation. You could use a non-vascularized corticocancellous graft with a compression screw. The graft site can be either from the iliac crest or the distal radius. It's a matter of personal preference. There have been a lot of studies and opinions more to say that that the quality of graft harvested from the iliac crest, especially when you're doing a corticocancellous bone graft, is of a better quality. It all depends upon what age of the patient is and what quality of bone you're dealing with. But there is no real evidence to suggest that one is better than the other, especially except in specific scenarios where you are dealing with osteoporotic bone, and if you want a structural support, so maybe you might think if you are wanting a little bit more of a cortical bone, then probably logically harvesting from the iliac crest would make more sense. You have inlay grafts and bone pegs, and then corticocancellous graft with compression screw, where the fracture site is exposed and the non-union site is freshened. You can see here, that's where the non-union is. And then you can use bone graft from the iliac crest or the distal radius, and then pack the graft in the non-union site and then compress it with a screw. And that should give a good result. Matty Rossi has described the bone grafting technique in which they use this two matchstick size pegs. And that technique involves a volar incision, two corticocancellous graft, as you can see in the picture here. And these grafts are sort of made to face each other on the cancellous side, to form a sort of a peg like this. You split the graft in the middle, get the cancellous surfaces to face each other, and you place it across the fracture site. and then you pack the rest of the area with cancellous graft, and that itself acts like an intramedullary screw or an implant, and you're adding the cancellous bone to improve the biology. You could use additional KYs distal to proximal for more support as required. So that was the Matrix technique. And if you have a humpback deformity with intrascaphoid flexion, as you can see here, here the height of the scaphoid is reduced and there is flexion. So here you need to use a wedge-shaped trapezoidal graft, and then in addition a screw across, as I have shown here in this picture. So this is the volar approach. You can use a very tiny laminar spreader like instrument to open up the fracture site, and then the fracture is curated in a graft which is carefully shaped to fit the defect, and you slot it into place and hold it with the screw. So that's a correction of a humpback deformity, the Fish-Fernandez technique. And when you're in a scenario when there is a proximal pole non-union with no arthritis, you can go in via dorsal approach. The fracture might just be a few weeks or a few months old. Use a non-vascularized bone graft. That's absolutely fine. You're not obliged to use a vascular graft, and you just fix it in the standard way. Only thing, because of the size of the fragment, you might need a mini HCS, or you should have a different armamentarium of smaller screws from the small fragment set as required, depending upon the size of the proximal pole. And it's always a good idea to offload the scaphoid by putting a K-wire across the scaphocapitate joint, as I mentioned earlier. Okay. Now, what's the dilemma? Most of us as orthopedic surgeons, I've given you a lot of options. Now, the specific option which hits most of us as hand surgeon, and many of us as orthopedic surgeons who are doing hand surgery, you are here with a scenario where you see a proximal pole non-union on X-ray. You've asked for an MRI and the radiologist has reported the MRI as avian for reasons I mentioned earlier. Then you're not sure how to proceed. And for that, I had, reiterate, repetition is always good. Be cautious in interpreting the MRIs and don't blindly trust the report. Look for yourself. Is there a low signal intensity on both the T1 and the T2 films? Is there any associated arthritis? What's been the duration of the non-union? Is it just a few months old, or is it several months old? Is it a year or two old? So you could get some of these presenting, almost 1.5 years, 2 years, 3 years down the line. So that is a separate sort of entity altogether, and that's a different beast, and that needs a different solution. So interpret the MRIs with caution. And when you talk about grafting options, we're talking about non-vascular bone grafts, vascular pedicle bone grafts, and free vascular bone grafts. So how do you choose among the three? So let's look at pedicle bone grafts. So the options are, there are various options. Again, it's a matter of preference and training. You could use the pedicle based on the radial volar carpal artery over the pronator quadratus, as described by Yamamoto et al. The Zeidenberg graft, most of us are more familiar with the 1-2 supraretinacular intercompartmental artery. And Brunelli et al. Have, based their pedicle on the index metacarpal artery. So it doesn't matter which pedicle. And then, more recently, the work of Doi et al. And others, they have described taking a free graft, if they could take it from the deep circumflex iliac graft, artery pedicle, or a medial femoral condyle. And the idea is to harvest it with a piece of bone along with the artery and use microvascular anastomosis to, attach it to the radial artery and plug it in the site of the fracture non-union. So you can see schematic diagram here. So that's the graft here. That's the thing being harvested from the femoral condyle. That's the graft itself across the non-union site. So these are schematic pictures. These are not my case. I don't have any personal opinion of doing a microvascular graft. So I stick to pedicular grafts where needed. So important thing, again, a lot of importance has been given to this clinical finding, again debated, but then one of the things which you could look for, is whether there's any punctate beating at the fracture site. So you curated the fracture and you sort of put two KYs in two fragments, joystick the fracture non-union site apart, and then once you've curated it, you look for punctate beating at the fracture site. And if there is no beating at all, and the proximal pole looks a little bit dysvascular, then it might be a prudent idea to proceed with, some people would say, although that's debated, you could go on to do a, vascular pedicle bone graft rather than simple cancellous bone graft. So some people give a lot of importance to this finding, punctate bleeding at the fracture site. But let's look at what the literature says, So we'll trace the literature, right from the beginning of the century. So, Doy et al., they got very impressed with vascular bone grafting, and they said they did 10 cases of chronic non-union, which they showed 100% union at 12 weeks. Then a little bit later, Merrill et al., they did a comparative study. And in 2002, they did a meta-analysis of literature, and they showed that non-vascular bone grafting, union rates of 47, but vascular bone graft, 80% union rate. So a significant improvement whenever you use vascular bone graft. This was the literature coming around at the beginning of the century, at the turn of the century. And then, Sheen et al., they published in Mayo Clinic, and then 2008, they did a comparative study, and they looked mainly at proximal pole non-union with established AVN, and they showed that, pedicle bone graft showed 40% union, whereas medial femoral condyle free graft showed 100% union. So, huge shift in, the success rate 40 to 100%. So they made a very strong argument for using a microvascular, medial femoral graft in proximal pole non-union. So this was in 2008. But then, slowly, as more and more literature began to emerge, this is the work from Richard Pinder and Mark Brewster, and this is from 2015, the Journal of Hand Surgery, the American edition. They looked at a large number of patients, not just 10 or 20 patients from individual series, but they looked at 48 publications all across the globe, 1,602 patients to meet the eligibility criteria. And what they postulated was vascularized and non-vascularized graft had an estimated union rate, and they independently assessed the studies. Uh, Not much of a difference, 92% versus 88%. So that's not a huge difference, 4% only, if you consider the amount of extra time and the technological expertise, the surgical expertise needed to do a pedicle bone graft versus cancellous bone graft. So the difference, I mean, did not seem to be very significant. And they concluded that the current evidence did not demonstrate a significantly superior method for scaphoid non-union using vascularized bone graft. They concluded that a randomized RCT would probably be best, but the numbers required, it's really unrealistic to get a RCT to do this. You don't get scaphoid fractures in that numbers to do a prospective study. It's all retrospective data we're relying on. So the paradigm shift which we have seen, this is from 1985, David Green's book. They talk about scaphoid non-union and bone grafting. And in his case, none of the 5 patients with proximal pole was, with AVN achieved successful union. And this is in 1985. And compared that with 2017, the success of scaphoid non-union is independent of the proximal pole vascularity. And they concluded that the proximal pole infarction is decidedly rare and vascularized bone grafting is seldom required. So this, seems to suggest a paradigm shift in approach, from, some people who would swear that vascular bone, pedicle bone graft is a must for all proximal pole non-unions. And then there was a very high chance of AVN, and especially if there's AVN, there was no other way other than a vascular bone graft, pedicle bone graft, or a free vascular graft. So that was the message which we got in the beginning of the century. But the last 15 years or so, the pendulum has swung decidedly in the other direction. So this is more literature, 2019. So we're getting closer. So this is from Alan Bishop et al., Mayo Clinic, again, New York. So they did a study. They looked at their
Ravi, your audio is not available. We are not able to hear you.
Okay.
series, not very, they did, 31 patients with iliac bone graft, 33.
So I think there is some technical problem with Ravi sir's presentation. Up to this time of discussion, Dr. Abhijit sir, can you comment on few points?
Yes. Is there any specific kind of a question that you want to ask me, or kind of
Just to summarize the
non-union management overview? So, like Ravida rightly mentioned, there are so many ways that you can skin the cat. But however, the location of the non-union, the duration of the non-union, the vascularity of the fragments, all of these will dictate the age of the patient, will dictate the management choice, or the choice of the bone graft that you select. Right from cancellous bone graft to a structural cortical cancellous bone graft to a pedicle vascularized bone graft to a free vascularized bone graft. These are all the options that are available. However, with the advent of arthroscopy and arthroscopic assisted bone grafting for scaphoid non-unions, the need for a pedicle vascularized bone graft at least has almost been uh, obviated now. There is more and more evidence which shows that arthroscopic or minimally invasive bone grafting helps in maintaining the biology or the blood supply by keeping the envelope of the wrist joint intact, the soft tissue envelope, and thereby union rates are enhanced. So that's perhaps the latest thought. Although we don't have concrete evidence to this effect or to this kind of uh, effect of whether vascularized bone graft is better than arthroscopy assisted bone grafting. But we do know that it has similar kind of outcomes as compared to a pedicle vascularized bone graft. So more and more people who are practicing arthroscopy assisted bone grafting are giving up the use of a pedicle vascularized bone graft. So I think that kind of pretty much summarizes the
I apologize. I sort of lost my connection for a moment due to
yeah.
blackout. Am I okay to resume?
yeah, please.
Thank you.
So, thank you. So again, can you see me now? Are you
Not
able
yet,
to?
sir. Not yet. Not yet.
Okay, let me share. Let me share my screen again. Here I am. Okay, here. I think now you should be able to see me. Am I okay? Am I good?
Yeah, about to. Yeah, it is visible now, sir.
Okay, good.
Yes.
Sorry, my apologies. So, I mean, there was a technical problem with the internet at my end. So, Peter Ree from the Mayo Clinic, this is more recent literature, 2019. Most scaphoid non-unions do not require vascularized bone graft. However, they made an exception. In the setting of avascular necrosis of the proximal pole, vascularized bone graft should be used to optimize the union rate. So, in general, scaphoid geometry and carpal stability must be restored. So, they made an exception for proximal pole, non-unions with avascular necrosis, where they made a strong argument for role of vascularized bone grafts. So again, this is more recent as we follow the literature. This is from 2022 in a Bone and Joint Journal. This is from UK, a meta-analysis and a systematic review. So look at the number, 78 studies with 7,671 patients. So we're looking at a large cohort of patients here, 88.7% for, non-vascularized bone graft and 87.5 for vascularized bone graft. However, if you look at the study more carefully, you know, basically they suggest, while vascularized bone graft does not yield significantly superior results to non-vascularized bone graft in scaphoid non-union management, they did sort of exclude the proximal pole non-unions with AVN. So there's a little bit of bias in the patient selection, but the message was for the majority of cases is you don't always need a vascularized bone graft. So, and there is the group, the arthroscopy group, always making a strong case. So, if you hear Dr. PC Ho speak, and also European colleagues, Riccardo Lucetti from Italy, and then from Scott Wolf and Rancy et al. From the US. So, across the continent and the Atlantic. So they would always make a very strong argument for arthroscopic bone grafting. And, even if it was a proximal pole non-union, they would, stress on how, the arthroscopy preserves the biology or not damaging the capsule and the blood supply, and, how it is possible to get in a equally, robust amount of graft into the non-union site and fix it percutaneously and arthroscopic methods. So it's a matter of preference. But then if you look at where this all leads us, there's another umbrella review, and this is the latest literature we have here in September 2024. So what they suggested that AVN was a significant predictor of increased failure for both vascular and non-vascular bone grafts. So 97% for vascular and 93 for non-vascular bone grafts. So where does this all leave us? Well, frankly, I think it's a little bit of a eureka moment for all of us orthopedic surgeons who are probably, thinking whether this is, we are flirting with, what is probably the domain of a plastic surgeon, and is this the watershed line where we hand over and concede defeat to our plastic surgery colleagues because we might not all be individually trained in microvascular surgery? So this where we draw the line and we, call in the expertise of someone who's more competent in doing pedicle bone graft, or, I think it's a matter of training. Even if you had to do vascularized bone graft, unless it's a microvascular anastomosis, any competent orthopedic surgeon would have the skill subset with a little bit of training and interest to develop the skills required to do a pedicle bone graft without much difficulty. And I can say that from personal experience. But the eureka moment is like, for a majority of cases, the scales have tipped in favor of non-vascular bone grafts. So for majority of scaphoid non-unions, we can get away with, not necessarily requiring a vascular bone graft. So in a nutshell, the last 20 minutes or so that I've been speaking, most scaphoid non-unions will do well with non-vascular bone grafting. Vascular bone grafting is more demanding and time consuming, and it gives donor site morbidity, as we all know. So if you are a betting man and you play your cards wisely and do a well, planned surgery with good technique, and you play your cards well, you will get away in most of the cases, with non-vascular bone grafting. But then, for example, even in a proximal pole non-union, it's not mandatory. If it's a fresh case, I mean, not too old, few months old, there is no arthritis, you can go in through a dorsal approach, pack in a lot of graft, and then fix it in the conventional method, and you should still get a good result. One particular caveat is to try and offload the capitate, the scaphocapitate joint with the K-wire, in addition to give it the best chance at union. But then there is some special scenarios where you have a long-standing non-union, where you have a proximal pole non-union with, avascular necrosis, as has been picked up on the MRI, absence of punctate bleeding, previously failed surgery, you're doing a redo surgery, then, these are prognostic factors which are very poor. And here it is best to, do whatever it takes. You can't afford to fail a certain time. So even if the statistically there's not too much of significance, if there is some evidence that a vascular bone graft will get much better results, it's always better to take that chance and play your trump card and go in with the vascular bone graft. So in this case, this is a 44-year-old male HGV driver. We had done a vascular bone graft. So I did it this was a Xydem graft we did. And this patient went on to do well. And it's 18-month follow-up. And this was a 2 months old, 2 years old at presentation, a proximal pole non-union. So that's why we decided to do that. So a snack wrist, once there's established snack wrist, you could we are looking at salvage options, mainly in some sort of a proximal row carpectomy or, scaphoid excision and four-corner fusion. So this is a proximal row carpectomy. And for completeness sake, I'm showing you a case of a scaphoid excision and a four-corner fusion. These are all in established, snack wrists, and the mainly salvage surgeries once we have missed the boat for, doing osteosynthesis. So in summary, not all scaphoid non-unions are the same. It is very important to understand that. And we need to identify those with the poor prognostic factors, which I've alluded to, adequate imaging and workup, CT, MRI, sometimes both, clinical examination and peroperative findings, careful attention to each individual case to select the best option, and also understand what works best in your hands. What are you good at? That's also, I think, an important thing which needs to be stressed upon. In non-unions with poor prognostic factors, consider a vascular graft. For snack wrist, you can do a salvage procedure like a proximal row carpectomy or a four-corner fusion, or very advanced cases, a wrist arthrodesis. So thank you very much for your attention. And I'll hand over to Amit now to take the proceedings further. Over to you, Amit.
Thank you, sir. Uh, uh, it is highly appreciated because you have given very nice, excellent talk, and now we are able to understand the classification of non-union, and when once we have identified the classification, then we can proceed accordingly. So for orthopedic surgeons, we have to stop the non-union to progress, and then once non-union has occurred, you have to stop for snack wrist to develop. So treat at right time, then you can save the wrist. So I would like to invite all the faculty, if they have any comment or questions, it would be highly appreciated. Praveen
Yes,
sir.
Amit. Yeah, yeah. It was very nice, Ravi sir. Perfectly placed, all things very widely covered. And I think you mentioned, but I wanted to again re-emphasize that in our orthopedic training, or even all the orthopedic the trainees who come to the hospital, if you ask one question, why scaphoid goes for non-union, the only answer they tell is because of avascularity. So
Hello.
you correctly placed it fourth in the rank. So it is not that avascularity is not the only cause for scaphoid non-union. There, the instability, it being an intra-articular bone, synovial fluid bathing, all these things are good enough reason for the scaphoid to go for non-union, and avascularity is just one part of it. So that was a nice, important message, I think, which everyone should understand. And yes, we need not have a fixed protocol for all the scaphoids that I always put screw, I always put wire, or I go by Wurzeler approach, I go by dorsal approach, or I never do a vascularized graft. I think a surgeon who is regularly doing scaphoid need to be quite flexible.
Sorry, I missed the question.
Yes, depending on the patient, the fracture site, the kind of the patient profile. I think and also the intraoperative finding, you should be able to change your approach from putting a cancellous graft or corticocancellous graft or a vascularized graft. All of them have a role and we need to correctly choose them.
Rightly said,
So,
Praveen sir, that we should be well versed with all the techniques, and according to the situation, we should proceed for that. Oh, any other? Uh,
Correct.
I would like to ask Dr. Abhijit sir, because we in between we were discussing. Uh, Abhijit sir, what are your indication for choosing arthroscopic treatment of non-union? In which situation you will proceed for that? Means, Ravi sir, in which type of non-union you will prefer arthroscopic?
See, again, it depends. I mean, arthroscopy is just an extension of, what you do through open surgery. So I would suggest it's basically for me, the ones which I've done, I've started doing them. When I started doing them, I used to do only the delayed units. You could perk it, and very early I have been able to tackle on the more the complex unions required to delayed unions, and not the I won't take a chance in the poor prognostic factors which I alluded to. A very long-standing proximal pole non-union. I wouldn't probably take a chance, not with my level of arthroscopy skills. Maybe someone more skilled, like the people who are have more experience with this. We need to make sure that the step where I work in this case, arthroscopy also has its own learning curve. So I would reserve, if you ask me personally, for delayed unions and waist unions, I'm comfortable doing arthroscopically where I'm
fairly sure that I'll be able to get an adequate graft and then pack it across. The advantage of arthroscopy is, okay, you're not doing a capsulotomy, you're preserving the vascularity. The advantages are immense. But if it a possible non-union of any significant standing, then I know people like PC who would still go and do the same thing. But that is where probably someone like me, I mean, I would resort to an open surgery. That is for me my personal indication. I don't know. Abhijit has more experience maybe in this regard. He might be able to comment.
Yes. So,
I think if the scaphoid has a deformity, so those are the cases where it is better to do an open. Otherwise, if the deformity is not there, in those cases, the
If you
arthroscopy
want a
would be fine.
structural correction, yes. So,
Yeah.
correct, correct,
And when
correct.
we
So only
require
cancellous bone graft, yes.
yeah, so when we require a structural graft, in those cases, I think the open one only is better.
Correct.
So that would be the correct way to differentiate, maybe. So, and actually, PCO always tells that, and I also think that is a perfect indication is you put a screw inside and the fracture is not uniting, but screw is not loosened. So that is a paka indication for just going in there and packing out some bone graft, because that can happen if you've done a percutaneous fixation. Sometimes if the
Yes.
concentric compression is not there, there will be a persistent gap. So that is the indication, I think. Other than that, you can fluctuate depending on the
Yes.
case. Yeah.
Yes.
So, my
Yes.
question to
Very much so.
Praveen sir and Ravi sir both. So, have you encountered that sometimes dealing with the non-union and packing with the graft, the screw length is coming more than 22 centimeter, kind of 22 millimeter, kind of that? Is it happened with you?
After packing with graft,
Yeah, sometimes that you are opening the fracture site and you have curated
yes,
out, packed with the bone
yes,
graft, and
yes,
screw length is coming little bit longer than the normal, or
yes.
how
But
to correct the length of this scaphoid?
so correct. But one thing is using a graft in a non-union for me, but the biomechanical support is essential, but I would go more with the biology, because essentially we are trying to get the biology to heal. There are a lot of people who swear by just K-wires alone. They don't necessarily put a screw in a non-union. They would just rely on the biology and improve the biology by using appropriate graft, and they would just use K-wires and get along with it. So if you are in any doubt, and the standard rule for any scaphoid, you screen in 6 views, all planes, and do a live continuous screen if required. If the screw is out on even one view, or it looks a little bit out on one view, even the guide wire before you put in the screw, it's better to replace the screw and place safe and shorter, lens screw. But as long as the graft is packed nicely in place, if there's any doubt about the stability, you can always add a wire in addition to the screw. Even if the screw length is small, you need to make sure it's not extruding and you don't exceed the length. So that would be my take.
Yeah. Thank you, sir.
Ajit sir, would you like to present your case?
Just 1 minute, sir. Is my screen is visible?
Yes, it's good.
Yeah. So he is a 30-year-old male, right hand dominant. There's history of fall from bike 5 year back. There was injury to the wrist and it was treated conservatively. There's mild pain since injury and it was neglected. So this is the X-ray of patient. So there's, I mean that the exact history is not available, but the patient was telling that 5 year back he had some kind of injury, and since then he had this kind of pain. So, Ravi sir, what's your thought?
So the fracture itself seems to be, more towards the, its waist and more towards the distal pole. So if you look at the X-ray alone, and there seems to be some sclerosis at the fracture site. My concern would be the duration, since I would need to make sure, although on the PA view that you got, that there doesn't seem to be any radiocarpal arthritis, but it's always a good idea to check. And for me, whenever there's a doubt, I see X-rays, I see MRIs, but for me, it's a easy job to put in a scope and see the surface for yourself. You just need to make sure you're not dealing with the radial styloid arthritis. If it's even a grade 1 sort of or early changes of the radial styloid, you could still do whatever osteosynthesis you are doing with bone grafting. In addition, you just add a styloidectomy as required, just to obviate any future problem. So your fracture might go on to heal very nicely, but then if it's a 5-year-old non-union, you might want to do that in addition. So in this case, yes, then yes, you would want to go in, and this would be a long-standing non-union, so you could make an argument. You should keep your options open, and then obviously get a CT scan. And the proximal pole itself doesn't look dysvascular, at least on the X-ray.
Yeah. Is it an indication
So
of doing
definitely
MRI?
get a CT scan.
Sir, is it any indication of doing MRI in this case?
MRI, unless there's any in my book, it's a 5-year-old non-union. X-rays don't seem to show, for something which is 5 years old, you would expect some changes of avian. If I even suspected slightly, I would get an MRI. But then, for this kind, more important, if I had to choose between the two, an MRI not necessarily a routine, but CT definitely yes.
Yeah. Okay. So we open from the volar side, and this is the fracture gap. We open the fracture side, and we take out the non-union part, the sclerosed bone, curated properly. We pass the guide wire, fix with the cancellous bone graft from the distal end of the radius, and then this is the screw which is put, and this is the final X-ray after the surgery, and this is after 6 months. So it's united, and this is a outcome of the patient. Yeah. So I think this was a case.
Good. So just asking your curiosity, did you good results, very well. So did
Yes,
you opt for a CT or an MRI for this patient?
Probably,
No,
yeah, CTs,
you did.
CT is not
CT.
available. So yes, I would love to do the CT scan, but somehow probably the CT scan, I had done the CT scan, probably it's missed somewhere.
Okay.
And but MRI, certainly I will not go for the MRI because on X-ray and the CT, on X-ray the
No,
X-ray
I'm
yeah.
just
Ajit, sometimes when I curated all both the poles,
do work.
and then I find that we should put a screw or wire. Then sometimes it comes into my mind that we are not going to give any compression. So I usually just end up with the wires, because what I think that screw will occupy the more space than K wires. So it will reduce your graft also. So
how many months you immobilize with the wires? Probably, I think screw is helpful that you can mobilize early. So what's your thought that how long you immobilize after putting the wire?
at least 3 months
So the wires are inside or outside?
inside.
Okay. Okay. So I think wire is also a good idea. You can put 2K wires or guide wires, whatever is there. It's a important thing is that good biology, good vast graph, nicely packed graph, and then immobilization is the key probably.
Sometimes I think that immobilization is key
Yes.
in treating scaphoid non-union. So it's very good case and good results you achieved.
Yes.
So I think we are exceeding the time. So I would like to hand over Dr. Praveen Bharadwaj sir for his concluding remarks.
Okay, thank you very much, Amit. Nice case, Ajit. And
Thank you.
as Amit was telling, I think if suppose you are not giving compression, sometimes you suddenly feel like, what is my screw doing there? So, but yes, we need to have that kind of that thought also is there. If screw is there, no, it is going to provide more stability. But at this point, I think one important message which we need to give to our orthopedic friends, that it is not that screw is must for any non-union. Okay, because many times we, as Amit was also mentioning, this case I would have put a K-wire only. And once I have put K-wire, there are 4 orthopedic fellows who are observing. They suddenly look at me, sir, you are not putting screw. So, so it is not that all the non-unions require screw. I think here biology is more important. You have very perfectly
Biology
beautiful
is
cancelous
far more
graft.
important.
Yeah,
Correct.
and it has to just hold in place. You
Yes.
can hold it with wire, you can hold it with screw.
Yes.
And if the cancellous bone graft, one small concern what everyone has is it will get resolved. So if you are having that thought, we can take a corticocancellous, but that requires a real crafting. You need to get a real shape. You jam it inside, you get that feel in your heart. Yes, this is going to unite. But when you are putting
Yes.
cancellous, we need to really pack it nicely because a fluffy
Yes.
cancellous is going to get resolved. So that is a very important point which everyone has to take. So lots of
Yes.
learning. Thank you,
Yes.
Bhadwaj sir,
Yes. Yes.
big brother,
Yes.
and to you, Ajit.
Thank you. Thank
Nice,
you.
nice case indeed. And I'm
See
sure
you tomorrow,
everyone would
sir.
have, yeah, everyone would have enjoyed this. And tomorrow we'll switch over to the congenital hand.
See you tomorrow,
all, of,
sir.
all of you are welcome. See you tomorrow. Thank you, Amit, for
Thank
Okay.
you.
All the
organizing this.
best. All the best.
Thank
All
Thank
the
you.
you,
best.
everybody.
Okay.
Thank
Yep.
you.
Bye.
Thank you.
Bye.
Bye. Bye.
Bye,
Bye.
sir.
Thank
Yes.
you.
Bye. Thank you.
Thanks
Thank you,
very much.
Abhijit.
Thanks
Thank you.
to the
Thank you. Thank
IOA.
you. Bye.
Thanks to
Bye.
the
Bye.
ISSH. Really very fortunate to have such a webinar, and I look forward to many more of these. Thank you.
Bye, Abhi.
Bye. Bye,
Thank you
everybody.
so much.
Thank
Bye.
you. Thank
Bye.
you so much.
Bye.
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 Good night.
Bye.
Bye.
Bye. Bye. Bye. Bye.